I've had the pleasure of knowing David as a colleague, a research collaborator, and a friend for the last 25 years. And he's had just an enormous influence on the field of inflammatory neuropathies and its effects with the interactions with the foundation. He has served as a brilliant leader, thinker, and a creative individual, and has been a mentor to literally hundreds, if not even thousands at this point, colleagues, research scientists, medical students, resident trainees, fellow trainees, and patients. I would be, on a personal note, I'd be remiss if I didn't comment on his profound impact on my career development. So it's not possible to do David's career justice in these brief moments, but what I'd like to do is highlight some of the significant contributions he's made to our peripheral nerve community, and in particular, the foundation and research in inflammatory neuropathies. So who is Professor Cornblath? For those of you who don't know, he's a giant and a visionary in the field of inflammatory neuropathies. He graduated medical school from Case Western Reserve University, and then went on to his neurology residency and fellowship training at University of Pennsylvania under the tutelage of Art Asbury, as you've heard about. And Art was just a giant as well, and was David's mentor, actually. From there, David went on to Johns Hopkins, where he spent the next 40 years of his career, becoming director of the EMG laboratory, as well as rising in the ranks to professor of neurology and neurosurgery. Subsequently, he was a founding member of the Peripheral Nerve Study Group back in 1991, which was then renamed the Peripheral Nerve Society, where he went on to serve as the board of directors, secretary, and treasurer. More importantly, and many of you don't know this, that he was such a critical player in organizing these meetings internationally, bringing folks together, bringing pharma in, everything from scheduling, video to the rooms to the hotels and everything else. So it was a tremendous amount of work. He also served as editor-in-chief of the Journal of the Peripheral Nervous System, and was a reviewer for neuromuscular papers for at least 38 journals. So here's a picture of a young David. I don't know if I got a pointer here. There we are. So that's Professor Asbury there, and there's David in his residency program. What about his contributions to the field? Well, as of a few days ago, he has published 272 peer-reviewed papers over his career, and not just in Guillain-Barré and CIDP. He's written about diabetic neuropathy, toxic neuropathies, inherited neuropathies, muscle diseases, myasthenia gravis, and even Lou Gehrig's disease. So this was his first paper as a first author on a neuromuscular topic, which was, of all things, the clinical electrophysiology of infantile botulism. Who would have thought? Regardless, he went on to be a significant player in the field of our diseases. So he was part of the initial GBS study group, which was the first study that established the efficacy of plasma exchange in treating acute Guillain-Barré syndrome. He was one of the first authors to describe that the HIV virus was another virus that served as a trigger for Guillain-Barré. He established the modern diagnostic criteria for Guillain-Barré syndrome with Dr. Asbury in 1990, and then a year later with additional collaborators for CIDP. He identified the variant that we now know very well as acute motor axonal neuropathy, and by doing this, he had to travel to China in 1993, and there you see David in the back row and Art Asbury's in front of him, and this was just an explosive recognition of what was going on in China at the time. There were thousands of individuals affected with a paralytic illness, and they thought it was Guillain-Barré, certainly as the variant, but it turned out the electrophysiology was different, the clinical prognosis was different, and David and additional collaborators over subsequent years helped elucidate our understanding of Campylobacter jejuni as the trigger for this particular variant and its relationship to anti-ganglioside antibodies. David was part of the plasma exchange tandglobulin group that established the standard of care that we still use today in managing acute GBS, where that international study demonstrated that IVIG was as effective as plasma exchange for the benefit of GBS, but combined therapy was no better than either, and that we're still doing that to this day. Coming from that trial, he went on to establish modern electrophysiologic classification for Guillain-Barré syndrome. Over the last 12 years or so, he became increasingly interested in outcome measures. It was very difficult to sort of measure change in GBS patients depending on how they were affected and what outcome measures you were used. And what he did, along with many collaborators, particularly from Europe, was establish quantitative measures like grip strength, MRC strength scores, helped establish what is now routinely used as the disability score, the IROS, or Inflammatory Rash Built Overall Disability Scale, as well as the utility of the INCAT scores in measuring change in patients with GBS, CIDP, multifocal motor neuropathy, and paraproteinemic neuropathies. More recently, he helped us understand the role of COVID infection in triggering Guillain-Barré and the lack of an association between COVID vaccination as a trigger for GBS. And over the last several years, he's been instrumental in revising the European Academy of Neurology Peripheral Nervous Society's diagnostic criteria for CIDP. The first revision was 2010, and then the second revision just completed and published this year, and I'm cautiously optimistic that the GBS criteria will be coming out by the end of the year. You've heard all about IGOS for those of you who attended Dr. Jakob's presentations earlier. I won't belabor it, but David was there from the outset. He was critical in the organizing structure, involved in the steering committee. In fact, we just had a steering committee meeting earlier this week, and is currently the chair of the electrophysiology expertise group in the hopes of using this enormous database from IGOS to establish standard criteria for classifying these conditions. More recently, there's now a new trial, and I think Dr. Jakobs talked about the Annexon study going on in Bangladesh. Here you see David in Bangladesh examining a patient. This study is a complement inhibitor and has the first potential novel treatment for Guillain-Barré in over 30 years. What about his role with the foundation? Many of you may not know. He was at Estelle's kitchen table from the very beginning when the support group got established with Dr. Asbury. Here you see David, looks like he's receiving some sort of donation there, and Estelle in the back, absolutely delighted. He recognized the need to professionalize the Medical Advisory Board, and over the next 4 decades was a leading member of the MAB and encouraged and recruited global membership as well. He created the Center of Excellence program through the foundation to support the diagnosis and treatment, the accurate diagnosis and treatment of GBS and CIDP, and he helped establish the GBS grants program through the foundation, now having distributed $7.4 million to researchers in the field since 2004. For those of you here who have CIDP and multifocal motor neuropathy, you wouldn't be here today were it not for David's pushing for the expanded role of the foundation beyond just GBS to include these chronic immune-mediated neuropathies. Furthermore, he's been a leading organizer of the content for many of these GBS symposium, giving innumerable talks and presentations to patients. He helped create the 3-year Benson Fellowship. You've heard about this from the videos earlier today, and served on the board of directors for the foundation from 2012 to 2018, and he was critical on the board for recruitment and governance. And of course, behind the scenes, he's been very active in recruiting countless donors to help support the foundation. So David, on behalf of the GBS Foundation and our colleagues, your research investigators and collaborators, your protégés, and of course your patients, our patients, we want to thank you for all you've done for the foundation.
So Dr. Cornblath has always had an interest in research, and especially when it's collaborative and involves different experts from different countries getting together. So we designed this panel of Dr. Bart Jacobs from the Netherlands and Dr. Jeff Allen from Minnesota to discuss research and really kind of unpack it. So here we go. I think I'll just stay here. So Jeff or Bart, what does research mean to you? Jeff, go ahead.
Thanks, Lisa. I guess my mic's on. Everybody hears me okay? Yeah. So first of all, thank you so much for being part of this first annual Arthur Ashbury David Cornblath lecture. It's part of my training was with Dr. Gorson, and although I was not directly trained by Dr. Cornblath, you can be sure that over the last 15 years, it's been a lifelong education, and it's a true honor to learn from him, to learn from Dr. Gorson, and it's not lost on me those messages that were also from Dr. Asbury, and it's my honor to carry those messages forward to future generations. So thank you for putting this together and having me part of this. As far as what research is, it's the collection of data. It's a collection of information that is real, that's objective, that we can rely on to make decisions in an organized way. And it can be observation, making important observations about what happens in and around us in our environment, or it can be done in a more structured way, for example, within a clinical trial, where we put patients through more rigorous designs where we collect information and expose to different treatments and measure different outcomes.
Bart, can you hear me?
I can hear you. Can you hear me all?
That's okay.
Yeah? Okay.
So what is the basic research process?
Well, the basic research process is that I would say that you have a hypothesis about something and that you let the reality decide if that hypothesis is true or not. So very important in research is if it is evidence-based. So we are seeking evidence to make decisions in the clinic. And you could also consider what is the alternative? Well, the alternative could be, let's say, authority-based, that it is just a professor that is saying if this should be treated in this way or in another way. And you never, of course, know if the professor is right if there's no research. So I'm a very firm believer of evidence-based research.
And Jeff, if a researcher has an idea, how do they take that from an idea to a grant to how do they go about that whole process?
Well, it starts with, of course, an idea, and then once you have an idea, you put it down on paper, on writing, on kind of what your specific goals, your aims of the idea is, and then you develop a protocol and exactly how you're going to study that, with the details of the design of the study and what you hope to get out of it, and then from there, there's a whole process of proving the study from an ethical standpoint. There's a process for that. And then depending on what the study is, it can move forward or look for different funding sources, and off it goes.
So Bart, you've been on the grant committee for, I don't think, can you hear me now? Is that better? Okay. On the grant committee for the Global Medical Advisory Board, how does the foundation go about making decisions about how to fund research and how to select research projects?
So every year there are rounds where all the researchers can apply for a project, and they are just writing down the idea, why it is relevant, how they would like to do the research, and what funding they would need for that. That's all going through the committee, and the committee is then giving marks for that. So if it is a good project or a poor project, and then the committee comes together and they are discussing which of the projects is the best and should be funded. So I think that the GBS CIDP Foundation is very important in that sense, because it's not so easy to find funding for these rare diseases. So I think you're one of the most important funding agencies for this research.
And the people on that committee making those decisions, are they all US based? Where are they from?
No, it is an international group. And also if you, sometimes I apply for funding as well. And at the moment that I'm applying, I'm not allowed to vote. So I'm not part of the committee at that time point. So the others will decide if it is good enough. And I think that's also the way it should go. So it's a very objective judgment about the project.
And Jeff, you've been involved in some new collaboration with CIDP. And can you describe the role of different countries coming together in that project, INKBASE?
Yeah, especially with rare diseases, it's really important to do these things together. We talked a little bit about INKBASE this morning, but this idea where if we really want to study a rare disease, the more collaboration we have, the better, so that we can start to bring out some of the nuances of the disease. So that means investigators across different sites within the US to get together and collaborate, but also international centers as well. So IGOS was probably the best example of that, and we're hoping to model that with INKBASE, the INKBASE collaborative.
Bart, thoughts on that sort of cross-country collaboration?
I think that international collaboration is absolutely key, especially for rare diseases. So you need a sufficient number of patients for research, but you need also a sufficient number of experts. And I think international collaboration is really the way to go.
So this is a question I'd love both of your thoughts on this. People have said to us, you've invested so much in research, but we don't have a cure. Is the research working?
Yeah, we talked a little bit about research in the CIDP space this morning. Gosh, there's so much happening over the last 5 and 10 years, understanding antibodies in our diseases, understanding different ways to measure them, looking at how to get better, more out of current existing treatments, new treatments and new clinical trials that are coming along. We all want this to move faster. We all want it to know more. We all want to know what the cure is. But it's remarkable how much is really happening, thanks and support to the foundations like the GBS CIDP Foundation that allow us to do this work. And with INKBASE, this study is just in its infancy. And so watching this come together and the information we'll get out of it over the next couple of years is very exciting.
And I think there's also a very unmet need to find better treatments at present. So I understand the frustration about better treatments very well. But I think we are now in a unique situation that we have all these cohort studies. We have a better understanding of the diseases than ever. And also there are many new drugs coming available, usually from other areas, let's say from rheumatic diseases that have a profound effect on inflammation that can now be tried in GBS and CIDP. So we are in a very exciting time at present for treatment development for GBS and CIDP.
So, jumping off from what Bart just said, Jeff, why is it important for people to participate in clinical trials?
Well, we all want to find new ways to treat these diseases for GBS, MMN, CIDP, and related disorders. And whenever you're talking about a rare disease like this, it's hard to find the right person, the right patient in order to put in these trials. And so the more collaboration we have amongst investigators and amongst patients and investigators, the better, the more successful we'll be likely to be. Not every trial is for everybody, but it's nice to have those available for people that are interested.
Bart, thoughts on clinical trials?
Yeah, I think it's the only way to find a better treatment. So sometimes you hear from patients, why don't you investigate it in animal models, for instance, but you don't want a good medicine for a mouse with CIDP, you want a good medicine for a person with CIDP, and mice are different from persons, although we can learn a lot from mice too. So it's the only way out. If you want to find a new treatment, we need a strong collaboration with patients and examine what is the good treatment.
So you said that it's an exciting time with the new trials on today and on the horizon. Compared to 5 years ago, we're in a different space with research. Can you comment on that respectively?
Yeah, so I'm now talking about Guillain-Barré syndrome, for instance. The last treatment that was developed that is currently used was in 1992. So that's 30 years ago. And after that, there were new trials done with new medicines and with new treatment regimens, but unfortunately, they were all negative. So we are still using the same treatment 30 years ago. As you see now, what happened in the last 5 years, that there are many trials now ongoing or are in preparation. There's a lot of interaction with industry to talk about the best trial design. There's also a lot of participation with patients about trial design. So patients decide for themselves what should be good outcome measures, and the FDA, for instance, is looking carefully after that. So this is not only about researchers, this is definitely also an interaction with patient and patient organizations. So I think all that was done in the last, let's say, 5 years. So we are living in a different area.
So Jeff, how can you encourage people about research? And I know you've been involved with InkBase. What's most promising to you about that?
About InkBase? Yeah, so it's just the opportunity to really gather a uniform set of information on people that we think have CIDP and follow that prospectively over time. So it's nice that these options are available, and I'd encourage everybody to talk to their doctors, to look up the Centers of Excellence sites to see what trials are near them that might be appropriate for them, and maybe get in touch with one of those Centers of Excellence to see if they have anything that might be suitable.
Okay, last question for both of you. Bart, you can start. If you were talking to a major donor, what would you tell them about why it's important to donate towards research?
I would say, first of all, there's an unmet need. There's a very important patient category that are suffering from their disease, and we need to find a solution for that. So it's a major clinical relevance for that. The other thing is that we are in an excellent position to find a better treatment now, because we are so very well collaborating at present internationally. We have all these cohort studies, we have a better understanding of the disease than ever. And we have all these very potentially interesting new drugs that come from other areas where we, I think, should apply to patients and see what works. So this is a unique opportunity, much better than, let's say, 5 years ago, to step in and donate.
Jeff?
Yeah, we know we have these diseases and they have this certain level of disability that can be associated with them. That's not trivial. That can really be quite substantial in some people. And we've got a number of major unmet needs in the inflammatory neuropathy world right now. And as exciting as it has been to see some of this research happen over the last 5-10 years, we still need to do a better job at figuring out diagnosis, figuring out disease activity, and figuring out medications or option ways to treat people that are equally as affected or more, but less burdensome on the side of the treatment burden. So doing research to improve diagnosis, improving the understanding of disease activity, and improving our treatment options is really, really critical.
Thank you both so much. I think our time is up. We're so honored to have these esteemed doctors with us and share their thoughts on research. Thank you both very much.
My world was turned upside down in a matter of seconds. Simple everyday tasks have become very challenging. There's days where a shoe might have worked the day before and I can't put it on that day. And I've chucked it across the room out of frustration. And I've cried and I've had my pity party. The most frustrating thing about MMN is I can't walk normally. I can't run. I can't do things that I loved doing, that I had a passion for. And now I have to find a new passion, a new way to do things. You're still normal, but you have a new normal. And I had to come to terms with that. I just suck it up and say, okay, figure out a way to do this. You're gonna get this, you're going to do it. I was very lucky to find an MMM social media group. They get it. They get me, we get each other. They are my MMN warrior family. I also talk to my doctor frequently about how I'm doing. He isn't a mind reader, so I need to advocate for myself to ensure I'm getting the care I need to manage my MMN. MMN has taught me to not take life for granted. I truly appreciate what I can do. I'm grateful for the things I can do in my new normal.
the response that the immune system makes toward the peripheral nerves. And so I've spent the last 15 plus years trying to understand what causes GBS and CIDP so that we can come up with better treatments to prevent and cure the disease. So my goal today is to demystify the immune system, because I think we need to understand the immune system to understand GBS and CIDP. So at UCLA, I teach undergraduates immunology, and I also teach the first-year medical students. So I'm going to give you everything I know in the next 40 minutes. So if you have any questions, please write them down and ask me, because the immune system, as all of you know, is super complex. If there's anything that I say that you don't understand, please write it down. My presentation will be fairly short, and we'll have plenty of times for questions. So feel free to ask anything. There's no such thing as a stupid question. All right, so let's get started. So what's the immune system's job? And in one word, it's defense. Its job is to defend us against foreign invaders, immune threats, like viruses, bacteria, and fungi. So we've heard about viruses in the news recently a lot because of this little thing called COVID. But there's also other types of viruses. Monkeypox is a virus, polio is a virus. Bacteria is another type of immune threat. Strep, staph, E. coli. Strep can cause pneumonia, staph can cause skin infections, E. coli can cause urinary tract infections. Fungi, so thrush, Candida is a type of fungus, and it can cause things like thrush, which is this pretty painful mouth condition. So these are all immune threats that we need to protect ourselves against. And so the immune system's job is to act like a shield. And it prevents all these foreign invaders from coming in and attacking our bodies. So I was talking to a colleague last night, and he likened the immune system to the gear that a football player wears. And there's multiple different parts to this gear, right? There's a helmet, there's shoulder pads, there's a mouth guard. So they're all there to help protect the football player, but they all have a slightly different purpose. And we'll get back to all the different parts of the immune system in a little bit. So when we talk about the immune system, what are we actually talking about? So your doctor will draw your blood to look at your immune system. So you go and get a CBC, right, a complete blood count, and they'll look at the white count and tell you something about your immune system. But it turns out the blood is actually probably the least best place to look at your immune cells. It's there, and that's why we use it. We use it because it's easy to get, right? You stick a needle in your arm, and hopefully some blood comes out, and we can look at it. The immune system actually lives in a lot of other places as well. So I've made this, or found this diagram online where they've kind of labeled all the different parts of your body where your immune system resides. And I've boxed here bone marrow because that's the site where your immune system is generated. That's actually where all the immune cells come from. So when people talk about bone marrow transplants, right, the reason it's bone marrow transplant is because the bone marrow is the source of the immune cells that they want to develop. Okay. In addition to the bone marrow, which is the source, there are these things called lymph nodes, and you can often feel them when you're sick, and they get big because when you have an infection, your immune cells that are living inside your lymph nodes start dividing and getting active and bigger, and that's why you get this growth in your lymph nodes. So if you have a throat infection, you get a lymph node up in your neck. If you have an infection on your foot, you'll see a lymph node maybe like where it's draining in your knees. So we have evidence, right, that the immune cells are also living inside your lymph nodes, and they're actually sentinels there. That's where they go and serve as watchdogs to see if there's any infections. And if there are, and if they sense an infection, then they start to get activated and do their job to defend. All right, so what are the different parts of the immune system? If you took a lymph node, ground it up into little bits, and looked at it under a microscope, you would see that there's lots of different types of immune cells. And I'm not going to cover all of them, but I just want to tell you about 3 of the big ones. So 3 big immune cell types that you will hear about are macrophages, T cells, and B cells. And these are the main players because they do most of the important jobs of the immune system. There's other things that you may have heard of, like mast cells, eosinophils. Those are also important, but I think these are the most important for understanding GPS and CIDP. So macrophages are the early responders. They're the ones that get there first, they're really fast, and if they see something that they see is dangerous, like an infection or a cancer cell, something like that, they'll call for help. And the cells that they call in are the T cells and the B cells. And the T cells have the special job of actually killing infected cells. So if a cell has a virus inside of it that's now gone in and wreaked havoc, the T cells will actually go and kill the infected cell in hopes of also killing off the virus and controlling the virus. The B cell has a special job of making antibodies. So we've heard a lot about antibodies with COVID and other conditions that are in the news, but the antibodies are important because they can actually directly neutralize the virus. So T cells and B cells are a little bit slower, but they have a very special property, which is that they're specific. That means that they actually can recognize particular kinds of viruses and bacteria and fungi, and as a result, they have a more accurate response. They know who they want to kill and what they want to kill, and so they actually are very, very good at defending your body against these foreign invaders. They also have another property called memory that we're going to talk about in a little bit, which means that they can actually get better and better every time they see that same virus or threat. Okay, so let's just walk through an example of how the immune system works. So let's say you are a farmer and you are on a farm with lots of ducks and chickens, and the ducks and chickens are infected with the flu. So they have avian influenza, and they pass it on to you because you're working with them, and the avian influenza infection goes into your lungs. So what happens? So let me see if this will work. Can't see that, huh? Okay, so on the left side of this figure are these cells that have these little hairs on top, and those are supposed to represent lung cells. So those are your lung cells called epithelial cells, and they get infected with the virus. The virus actually goes inside of them and starts using its machinery to make more copies of itself and causing all sorts of trouble. When it does that, it releases some signals that cause a macrophage to know that there's something wrong, and it goes into the lungs. The macrophages see this, and they're like, okay, shoot, there's something going on here that's not right. And it sets off a bunch of signals as well. And those are called inflammatory cytokines, and those little red dots on the bottom there are inflammatory cytokines. And those signals go out to the T cells and B cells. So the T cells, which are on the far right, will then come on in, and they, as I told you, have these specific receptors, and they're able to see the virus-infected cell and kill them. And they can also make these cytokines that are also cytotoxic, as well as making other kinds of molecules that will kill cells that have viruses in them. And as we already talked about, the B cells are also there, and they will come in and make antibodies to go and neutralize these viruses. So the main goal all around here is to minimize the virus, kill the cells that are virally infected, and get rid of that virus altogether. And that's how your immune system is supposed to work to try to protect you against these foreign invaders. All right, so let's say everything goes great, and you recover, you get rid of your virus. You're still a duck and chicken farmer. You get exposed again to the same virus. What happens? So, multiple choice quiz. One possibility is you get sick again. The second possibility is you get more sick than you did previously. And the third possibility is you have a milder disease. And so all of these are possible, but it turns out that most people actually will have a milder disease. And so why is that? And the answer is because we have this property in our immune system that T and B cells have, which is immune memory. And what I mean by immune memory is that your immune system has the ability to respond to an immune threat more quickly and more effectively with each subsequent encounter. So it gets better and better and better at recognizing the immune threat and mounting a better response against it. So that statement is illustrated in this diagram here. So let's say you get your first infection. So on the x-axis is a timeline. So let's start at the beginning, when you first get your infection with the flu virus from your ducks and chickens. Initially, that virus goes into your lungs and it rapidly divides so that you have a big magnitude, a great magnitude of virus load. Your macrophages come in quickly, and they say, help, help, help. T cells and B cells then come in a couple days later. It takes a while for them to get up to speed as well, but then they do a great job and start tamping down the virus load. The T cells and B cells are killing off the virally infected cells. The B cells are making antibodies, neutralizing the virus, and the virus goes completely away. But the immune response doesn't go completely away. It leaves behind a couple of very important cells called memory T cells and memory B cells. And those memory T cells and B cells have a very special property of being able to respond really effectively the next time you see that same virus. So if you get a second infection with that same avian flu virus, you now mount this bigger response quicker by your T and B cells because those memory T cells and B cells are kind of like little Hansel and Gretel, breadcrumbs telling the immune system, we've seen this before, this is what we do when we see this. And as a result, the virus is better controlled, there's not so much of it, your lungs are pretty healthy, not many cells got infected, and so altogether, things are much milder for you this time around as a person. So this is immune memory, it's super important, and one of the reasons that we are, in general, able to defend ourselves against viruses and bacteria and fungi as well as we do. And this is also the basis for vaccines. So we've heard a lot about vaccines in the news recently, but what vaccines are designed to do is to make it so that we don't have to have that first infection. So instead of having that first infection, if you go to CVS and get your vaccine instead, you never get that virus load. You never get those viruses coming into your lungs and causing havoc, but you still get that T and B cell response. So the T and B cells are now told, this is what a virus looks like if you were to get an infection. And then they can make antibodies and they can start dividing and leaving behind those very, very important memory T and B cells. And so if you then get your first infection with the flu or with COVID, your T cells and B cells are already super good at responding against it because those memory T and B cells are there. And so you get this quick response, it's better than it was before, and the virus load is really minimized. And so that's why vaccines work. So get vaccinated if it's something that your doctor recommends. It is so much better not to get that first infection, right? You want to minimize the damage that the viruses are doing to your body. Okay, so this is what happens when the immune system works as it should. But sometimes, just like what we have faulty brain memory, we can also have faulty immune memory. And if you have faulty immune memory, one of the possible consequences is autoimmunity. So when we say the word autoimmunity, what we're talking about is a condition in which the immune system mistakenly sees our healthy tissue as a foreign invader or as an immune threat and starts to attack it. And there are more than 100 different conditions that we now recognize as being autoimmune. And those include multiple sclerosis, which is an autoimmune disease of the central nervous system, your brain and your spinal cord. Hashimoto's and Graves' disease, which are diseases of the thyroid gland, and I was met with a few of you in the audience who have thyroid disease as well as autoimmunity. Type 1 diabetes, which is the autoimmune disease that I take care of in my clinic. And that's an autoimmune disease where your immune system goes and attacks the insulin-producing beta cells in your pancreas. Crohn's disease, which is an inflammatory condition where your intestinal cells are attacked by the immune system. Rheumatoid arthritis, which is an autoimmune disease of the joints. lupus, which we call a systemic autoimmune disease because it's something that affects many different organs, psoriasis, which is a condition that affects the skin, and then most relevant to the people in this room, Guillain-Barré syndrome and CIDP are autoimmune diseases that affect the peripheral nervous system. Oops. So 5 to 10% of Americans are affected by autoimmunity. That's a giant number. So in a room with 10 to 20 people, one person will have an autoimmune disease. And this incidence is rising fast. So if you compare the number of people who had Crohn's disease, for example, in 1950 versus 2000, there's 4 times more people who had Crohn's disease. And so we don't know what's really underlying this very fast increase in disease incidence. It's too fast for genetics, right? So if you think about genes and how they evolve, this is less than 1 generation, 2 generations of people. So the ability to mutate your genes and have that be the underlying cause it doesn't seem plausible just from how quickly it's been happening. So there's some thought that it might be something about our environment, maybe how our environment is interacting with our genes, but it's something that I think a lot of us are concerned about and trying to understand. So the incidence is rising throughout the world, and in parts of Northern Europe, it's been very, very dramatic. So Guillain-Barré syndrome, as I mentioned, is an autoimmune disease of the peripheral nervous system. We know T cells, B cells, and antibodies are important in this disease. And even though the peripheral nerves are not infected and they're usually healthy to begin with, the T cells, B cells, and antibodies seem to think that there's something going on and going to attack it. And one of the interesting things about Guillain-Barré is that about 40% of individuals will have a history preceding the onset of their disease of having had a bacterial infection. And usually it's by this particular bacteria called Campylobacter jejuni. And so one thought is that perhaps the immune system thinks that the peripheral nerves are actually the Campylobacter jejuni. Maybe it got confused and remembered incorrectly what Campylobacter jejuni looks like and thought that perhaps it was something that's inside the peripheral nerves. And if you actually look at bacterial cell wall components of the Campylobacter jejuni and compare it to the nerve cell components, there's actually a striking similarity in some of the carbohydrate components of these 2 entities. And so on the left, these are really schematized, but are the 2 areas of the carbohydrates that I'm referring to that are almost identical. And so one thought, one theory is that what happens is something called molecular mimicry between the Campylobacter jejuni bacteria and the nerve cell, where they're so similar that your immune system confuses the nerve cells as a bacterial cell. And so it saw the Campylobacteria as an initial response, and then when it saw the nerve cell, it thought, I think this might be Campylobacter, and attacks it again. So, sorry, this got cut off on top, but this is just a schematic form of what one theory is of what happens in Guillain-Barré, but you initially get the Campylobacter infection. Your immune system has a very appropriate response against it. Macrophages come in, T cells and B cells attack it, antibodies are made, it damps down the Campylobacter infection, leaves behind these memory T cells and B cells. But then something happens where it looks at the peripheral nerves, thinks, oh shoot, here's the Campylobacter again, mounts another T cell and B cell response, this time against healthy peripheral nerve instead of the bacteria, and starts to destroy the healthy peripheral nerve. And so this is the second part of this is the autoimmune response. There are other conditions now where people have linked particular infections to developing autoimmunity later on. Most recently and in the news is the link between Epstein-Barr virus and multiple sclerosis. So there was a study recently done that showed that many, many more people who have multiple sclerosis had a history of Epstein-Barr virus than those who didn't. There's been links between type 1 diabetes and enterovirus cytomegalovirus. Rheumatoid arthritis has been linked to a mouth commensal P. gingivalis. And lupus has also been linked to Epstein-Barr virus. So this may be a more universal phenomenon than we appreciated before. All right, so just to summarize then, the take-home messages are that our immune system evolved to help us defend against foreign invaders, but that system isn't always perfect, and autoimmunity can happen if the immune system confuses foreign invaders with the healthy tissue. And so one of the strategies for treating autoimmunity is to dampen down the immune system. IVIG, glucocorticoids, those seem to be effective in a fraction of patients, and the reason we think they work, we're not totally clear exactly on the mechanism, is that it helps to just cool everything down. What we're trying to do in my lab is to understand better which parts of the immune system are not working correctly, which parts of the immune system are not recognizing the antigens correctly, for example, and trying to target those particular parts of the immune system so we can have more effective therapies, especially for people who don't respond. So I just wanted to give you a little flavor of what we're trying to do in our lab. We have some GBS CIDP mice. So we have mouse models that spontaneously develop a condition where the immune systems in the mouse bodies will go and attack their peripheral nerves, and they have quite a few similarities to human GBS and CIDP. And unlike patients where it's hard to get samples of nerve, we can take the nerves from our mice and dissociate them, and then do something where we can purify out just the immune cells that are attacking the peripheral nerves, and then really, really, really study them. And we have this really powerful new technique called 10x single-cell RNA sequencing, and that's a way to look at each individual cell and to understand everything about it, all the different proteins it's making, what kind of specificity it has. And by doing that, we're just starting to tease apart what are the different parts of the immune system inside the actual tissue, so we can look at basically the bad actors, and to try to understand where we can intervene and stop those immune cells so that we can try to reverse or prevent the disease. This is something that we would love to translate to human samples as well. But we start with the mouse models just to make sure that we have found some of the targets that we want to validate in humans. On the right here is an example of some of the data that we can get doing this. So each of the dots, they look like clumps, but they're actually made up of tiny little dots, kind of like one of those oil paintings that it's made up of tiny little dots. But each of those individual dots is one cell. And so we took 3 mice, took their nerves, took the immune cells out of them, and we can see many of the cell types that we thought we would see, which was at least confirming what we thought was going on, and also a bunch of other kinds of cells that we weren't even aware of was inside the nerves. So you can see there's CD4 and CD8 are the T cells. There's macrophages, that's what the MAC is. There's B cells in there, that's what the B is. The plasma cells are the antibody-producing B cells. And then there's a whole bunch of other things in there that we're just starting to get a handle of, on. All right. So I have a big group of PhD students, undergraduates, postdocs. So those are people who have completed their PhD and doing an extra 5 years in lab, as well as assistant professor in my lab, and we're all working hard to try to understand what causes autoimmunity, and in particular GBS and CIDP at UCLA. So we've also received support from the GBS CIDP Foundation in the past. I'm really grateful for it. So that's it for me, and I'm happy to take any questions.
First of all, excellent.
Thank you.
This is probably the most informative talk I've seen about immunity and autoimmunity, so
Thank you.
I really get it now, so thank you for that. For those of us with CIDP or GBS or MMN, a lot of us have coexisting, oh, hello. A lot of us have coexisting conditions.
Yes.
Autoimmune as well.
Yeah.
Why is that?
Right.
Like, when I got CIDP, about a year later, it brought in all its ugly friends, so I want to know why. So.
Yeah, no, that's a fantastic question. So for those who didn't hear the beginning part, but there's lots of cases where people have CIDP plus another autoimmune disease, and why is that? I think originally many of us thought that this was genetics, right? So that particular parts of your immune system are inherited, and so therefore people in your family might be more predisposed, and that certain of those predispositions not only predispose you to having autoimmunity against your peripheral nerves, but also maybe against your thyroid or against your skin or against your joints. And those genes, for example, might be important for just upping up your immune system so that it's even better than the average in fighting off different infections, but the cost that came with that was potentially autoimmunity. So I think that's one thought. The other is potentially that there's something about our environment that we're living in, right? That may also be just upping the bar for how our immune system responds to things in general. And so we don't really know is the bottom line. We're starting to do things like genome sequencing where we're looking at one person's entire DNA sequence and looking to see how those get expressed into different parts of your immune system. And as we're doing that, we're learning a little bit more about the particular genes that may be predisposing you to not just CIDP, but autoimmunity, more autoimmune diseases in general. In type 1 diabetes, and the kids that I see in my clinic, type 1 diabetes, Hashimoto's, thyroiditis, celiac disease, those three go together a lot. And we think that's part of the MHC, so we didn't talk about this, but one of the ways that T cells see the different immune threats is by having other cells present these antigens, these pieces of the immune threats to the T cells. And it's the way it's being presented to the T cells that might be part of it. So we don't know, but that's a really big question, is why do we see multiple organ? I also take care of patients who have a particular monogenic condition called APS1. So we know there are certain genes that are predisposing to multiple different tissues, and they have multiple autoimmunities against a lot of different seemingly unrelated organs. Yeah. Yes.
I have a question.
Wait for the microphone. Hang on a minute. Wait for the mic.
I have a question regarding toxins. You mentioned that there's a lot more people receiving damage, or we're seeing more people over time.
Can you raise your hand, whoever's
Yes,
speaking
right
now?
here.
Okay,
in the back.
gotcha. Yes.
Over time, we're seeing more people affected by, pardon me, anti-immune problems.
Yeah.
Of course, we're having more people also.
Yes.
So I don't know what the percentage is in the population mix.
Right.
But my question, coming back to, you have one of your slides, you had fungi. All right. In the relationship to the mycotoxins, are you looking at mycotoxins and fungi as the same?
Yeah, that's a great question.
All right. Now the reason why I say that is that if we have mycotoxin problems, it comes primarily from our environment. So we're pointing to where is this all coming from, and what is affecting us. It's our environment, what we're eating, what we're drinking, so forth and so on, pollution, so forth. What about detox?
Yeah.
What can we do in that regard? Now, mycotoxins are certainly more associated, or as I see them, in the kind of the family of mercury and things of this nature, where they get into your system and they're hard to pry out. Yeah. So what kind of opportunity do we have for like I mentioned, detox? Because I think that's where I come from, is the need for the detox.
Right.
Thank you.
So fantastic question. So to address your first question about the number of people in the world is increasing, but it's actually the incidence of the percentage. So per 100 people, we're also seeing that increase. So it's not just about having more people in the world, it's actually of the people that we have, the fraction of people with autoimmune diseases rising. And then in terms of your question about environmental toxins like mercury and fungal toxins, I think those are all possibilities. We haven't explored them, but it seems like it's something about the environment that has changed in the last 50 years and how it affects us, and affects our immune systems. That might be underlying some of what we're seeing with this increase in incidence. The other really interesting connection has been between infections and autoimmunity. So as infection rates have decreased with developing countries, the rate of autoimmunity has increased. And this is called the hygiene hypothesis, the idea that the clean world that we live in somehow isn't allowing our immune systems to be correctly educated, and as a result, they're more prone to autoimmune disease. And this is a hypothesis that's really hard to test, but it's correlated very strongly. The countries that have less infections have more autoimmunity. So that's another clue into our understanding of what's happening. But I appreciate your comments, and I think those are things that we need to think about. Yes.
First, thank you. Excellent talk. Can you talk a little bit about monoclonal antibody therapy?
Yeah. And for what condition in particular? For COVID? Okay. Yeah, so one of the thoughts in COVID is that if your immune response isn't quite good enough, so in the beginning I was telling you that we mount this immune response against viruses, and the idea is to neutralize the viruses and to kill off the infected cells. But let's say your immune system's not quite good enough. Some people have immune deficiencies, right? And so if your body's not quite good enough, one thing you can do is to replace the antibodies that they were not able to make with a monoclonal antibody against COVID. And so that was the strategy behind the use of monoclonal antibodies with COVID, is that we could infuse back into you the antibodies that your B cells were supposed to make if you had an effective immune response. But for whatever reason, some people, for example, are taking medications where their B cells can't make antibodies, or they have an inborn genetic condition where their B cells just don't make antibodies very well. Those people would benefit from having monoclonal antibodies if their doctors could see that they didn't have a good antibody response against the COVID.
Question over here.
Yeah.
If your body is naturally, in the beginning, fighting an infection, and you're introduced an antibiotic, and that antibiotic is really not helping, or doesn't help your process of recovery, is that a negative, or does it slow down your natural ability to recover?
Yeah, that's a great question. So the question is, if you take an antibiotic, if somebody gives you an antibiotic for an infection and it doesn't work, how does that affect your natural immune response? So there's a couple of reasons that your antibiotic may not have worked. One is that you don't have a bacterial infection. You have a virus or a fungus or something else, right? Or even an autoimmune condition. But you're given this antibiotics in hopes that it's a bacterial infection that will be susceptible to the antibiotic that you were given. The other possibility is that your bacteria is resistant to the antibiotic, and that's become a bigger problem globally as we've been using more and more antibiotics, is the bacteria have fought back and figured out how to not be affected by the antibiotics that we've manufactured in our pharmaceutical companies. And so if that's the case, that you take an antibiotic and it doesn't work, is that a bad thing in terms of your immune system? So the antibiotics now are pretty specific in killing off the bacteria, right? And so if it's not working, if it has no effect on the bacteria, hopefully your immune system can still mount an immune response against the bacteria that's there and do its job. So in general, you don't want to take an antibiotic unless you know it's going to work on your bacteria, and we can usually get a specimen of your urine or your blood or whatever it is and just test that it's going to work. And that the reason is you want to make sure that you're not helping that antibiotic resistance to develop in the bacteria. But I think in general, your immune system should, if it's fully intact, should still be able to respond against the bacteria that's there, or the virus, or the fungus.
Yes, thank you. One of the other things that can trick the immune system into attacking healthy tissue is vaccines, and that's what happened to me. My GBS and now CIDP was triggered by my J&J shot, unfortunately, last April. I was one of the 100 cases that led to the FDA attaching its warning in July. GBS is a known risk and documented risk with any vaccine. So my question is, not to harp on that, but just in your research, have you looked at what happens there? And is there any difference between, say, the immune system reacting in this way to a virus or bacteria as opposed to the process that happens with a vaccine?
Right. No, that's a great question. I think that's one of the big things that people are keeping a really careful eye on is, are certain vaccinations predisposing to GBS, CIDP? Are certain infections predisposing, like Zika, predisposing to GBS and CIDP? So I think what we now know through your experience, as well as some of the Zika cases as well, is that both of them may have a predisposition to GBS, and we're not exactly sure what particular formulations of those vaccines may have been more predisposing than others, right? Because the Johnson & Johnson one was the one that's been linked, but the other ones have not. And so Zika as well, what is it about having a Zika infection that does something to your immune system, whether it's the recognition of the Zika and having this faulty memory that we were talking about, or just overall revving up your immune system in a way that brings out some of the autoimmune attack. So it's a great question. I would love to study it. I would love to be able to look at it more. And I think one of the things that we're trying to develop is how do we actually get COVID into our mice, because mice don't naturally get COVID very easily. We can put some human genes into there to make them more susceptible, but that's one of the things that we're trying to understand is how a virus or a vaccine can rev up or change the immune system in a way that might predispose it to certain autoimmune conditions. Yes.
Good morning. First of all, thanks for being here and flying across the country for us. We really appreciate it. My question is very simple. So we all have an autoimmune disease, and yet they keep putting immunoglobulin Gs into me and revving up my immune system, it seems. Wouldn't that be counterproductive? I don't understand why the two seem to go and work together.
Yeah, no, fantastic question. So you're asking about why does IVIG work, right? Because it's an antibody mix, right? We take lots and lots of people, we take their antibodies, we pull them together. That's a fantastic question. As you said, if you logic through it, it should be revving up your immune system, but it doesn't. It seems to actually cool it down. And we think maybe it's just by virtue of having so many different people's antibodies pulled together that it does something to just maybe sop up all the places where your antibodies against your nerves might be trying to bind, or it might be turning on the regulatory parts of your immune system. So there's parts of your immune system whose job it is to damp things down. And so if you can turn those up and make them work better, that might be part of it. But at the end of the day, we're not totally sure why it works in some people. But instead of doing what you're describing, which is what I would have guessed too, which is to turn on the immune system, it actually seems to bring it down. But you're absolutely right. It's a really good question.
Hiya. I have a question, and I'm not really sure we're allowed to know the answer. You said earlier that you can make a mouse have GBS.
Oh, yes, we have a mouse that has GBS. Yeah.
How do you, is that, you're able to like inject it with something and it just gets GBS?
No, it actually develops it spontaneously. It has a mixture of genes that seems to predispose the mouse to developing autoimmunity against its peripheral nerves. And that's actually that was something that I was working on when I was in training, and that's what I built my career on. And that's why my lab actually studies it, because this mouse model is really valuable in trying to understand what happens in people. We can try to understand what just spontaneously happens in a mouse with a certain genetic mixture, and why the immune cells go and attack the nerves.
neuro outpatient therapy attached to our building. So you could be my patient, starting an inpatient, and then want to come back to our outpatient, and I can actually collaborate with your therapist on the outpatient side. So it makes for a really nice transition of care, but it also allows us to work on patients from the acute side and then on the more chronic side. So that's a little bit about us and how unique our facility is. So it's been fun talking to a lot of people here and saying, well, you're a PT, you work on the leg, and you're an OT, and you work on the arm. Like, what the heck are you going to talk about with the face? And, you know, there's more to just walking and reaching and grabbing, as you know. When the foundation asked us to put on a presentation for facial paralysis, we understood that it was a very small and unmet need for you all because there's not really that many people who address it. And I'm assuming from the group that's in here, somebody has had some kind of difficulty with facial paralysis in here. So we wanted to kind of bring a little bit of exercises, because what good therapist wouldn't give their clients exercise and treatment interventions, but we also want you to understand what is going on. Like, why are you having this facial paralysis, okay? Don't worry, there's not going to be a pop quiz in the neuroanatomy section. It's all fun. But this is looking at when you Google facial paralysis, they're going to give you this definition of loss of facial movement due to nerve damage, and it can occur on one or both sides of the face. And it's weakness or paralysis of facial muscles that causes difficulty with eye movements, speech, chewing, and swallowing. That's what we care about, right? Now, this is very broad. When we're looking at facial paralysis, this is all of the causes not related to GBS or CIDP or any of the other variants. So the number one reason for facial paralysis is stroke. Makes sense, right? They have facial drooping. The second cause is infection, which is where the GBS, I'm going to call it the family, the GBS families live, and we all know that most cases are due to some kind of infection. Then you have Bell's palsy, which is probably the most common type of facial paralysis people hear about, but it's actually also known as idiopathic because they don't really know why you are having some facial paralysis. Then you have tumors, like brain tumors or facial tumors that are affecting the nerves, and if there's any kind of trauma, like a car accident. So let's get a little bit more specific with facial paralysis and in GBS and all of the other variants. So it follows your typical progression of paralysis, right? So it's going to be bilateral in nature, and it's going to be associated with any kind of limb weakness. Bilaterally facial nerve paralysis is what really cues your doctors in acute care to say, let's stop here, let's do some testing and figure out what's going on with this person, because truly in the world of medicine, unilateral facial paralysis is more common, okay? So if someone is presenting to the hospital and they have bilateral facial nerve weakness, that indicates to the doctor, we have to run some tests because it could be either GBS, it could be, I think there was Lyme's disease on there, and neurosarcoidosis. There's only a few handful of disease processes that present with this bilateral facial paralysis. And then if you are really, really lucky, you guys should play the lottery because only 6% of people in already rare disease will get this delayed facial palsy that occurs after your neurological symptoms have peaked in the hospital, okay? So really rare, but in 6% of these 27 to 50% of people get this delayed onset. So, what do you see when you have bilateral facial palsy? This patient actually is a patient with GBS, so you can see how they have absent forehead wrinkles, droopy eyelids. You don't see that they have dry eyes or excessive tearing, which is a whole nother issue. Drooping of the corners of the mouth. A dry mouth, a lot of people will say, man, my mouth is so dry, like even when I drink water, it doesn't feel like it's getting any moisture in there, or a cotton mouth. Impaired taste. Dysarthria, which is the inability to, or not inability, but the difficulty with speaking. Dysphagia, the difficulty with swallowing. And then synkinesis, which I find fascinating, is when it's a voluntary muscle contraction that causes an involuntary muscle contraction in another part. So what does that mean? I go to smile and my eye starts winking. That's not really common, but that can happen. So the neuroanatomy part. I love neuroanatomy, so I kept it very simple for everybody. And what I want everybody to appreciate from this slide is how the one nerve, let's see if I can have a pointer. Nope. Okay, I tried. But so what you're seeing in all the different colors are the different branches of the facial nerve, okay? So you can see that the different colors, and this kind of drives me nuts, and my OCD is going on high alert that the colors aren't matching, but the top part, the purple, if that part of the branch of the facial nerve is affected, that part of those muscles would not be working. So you can have either certain parts of the facial nerve be affected, or you can have the entire nerve affected. So you may see some symptoms or not. And generally speaking, the muscles of the upper part, not all muscles are innervated strictly by these branches. There are some overlaps. So again, take this with a grain of salt. It's very general, but you need to understand that you may have certain areas of the face that are not working because of what branches were affected. Now, this patient did not have GBS, but this is a good picture just to kind of show the severity of the facial paralysis. So what does it mean for us as clinicians and for you who are living with facial paralysis? Well, trivia, Dave, I see you back there. This is a good slide for you, buddy. Yeah, get your laptop ready. I got some good trivia facts for you. Anybody go to that last night, by the way? It is hard. Yeah. Jeez Louise. Okay. Anyway, so we can see if we have weakened muscles of facial expression, we are not going to be able to smile, to be sad, to be angry. Well, why is that important? If anybody went to San Diego Symposium and heard Michael Coleman speak, he is an actor, and he came up to us and he said, man, is there anything that I could do to zap my face, because I play Happy on the Seven Dwarfs and I can't smile. So that really affected his role to be able to work, and that really discouraged him. And of course, when he was diagnosed with GBS was right in the middle of him filming. So they had to do a lot of, take shots from the one side of the face that was a better smile. So it can affect your life a lot if you can't express what you want to express. The weak stylohyoid and posterior digastric muscle. What do we care about the muscles? Well, if you have impaired swallowing, you might need chopped food, minced foods, right? You might need to go pureed. You might start drooling on the one side because you can't keep the food in your mouth. Your jaw might not be coordinated to move in a certain way to chew. That can be very isolating, especially for somebody who loves to go out to eat with their friends or family members. They might say, you know what, I'm really embarrassed and I don't want anybody to see me chewing and going out. So they start disengaging in those normal activities. Dave, this one's for you, ready? The weakened stapedius muscle. It is the smallest skeletal muscle in the body, measuring only over 1 millimeter in length. But it has a huge impact on us. It is the muscle that is responsible for dampening loud noises. So if you have like a hypersensitivity or an overreaction to loud noises, this could really impact your life. I know from a personal experience with our son, he's 6 now, but when he was 2, he started getting some hypersensitivity to noises. We got him the headphones, we would go, to parades and everything was fine. And it wasn't until he was a little bit older, he was 4, and my husband and I said, you know what, let's take him to Disney. It's gonna be great. He's at a great age, he's gonna have so much fun. Let me tell you, we went from thinking we were the world's greatest parents to being awful and we're torturing our son because the noises were so much for him. He was scared, and then he was so anxious that he was worried that he was going to have another reaction, that he didn't want to go on certain rides. He didn't want to go to the characters. He didn't want to watch the parades. And if you think about it, if you don't address those issues, you can easily become isolated. And if you were in Dr. Gottlieb's presentation, all that depression then starts coming on, right? So a very, very small muscle, but a huge impact on our life. So what do we do about it? I think what we want you guys to get out of this is it's not a one type thing. It is definitely more an interdisciplinary approach. There's the medical pharmacological management of it, which you guys are more versed than I am in it with your IVIG and the plasma exchange and the corticosteroids. Then there's the rehab part where we fit into this. And then there's the surgical management of it, which now I'm not going to go into too much detail because you guys get a lot of this information throughout the symposium here. And you're aware of your doctor is going to go over which is going to be best for your case, correct? The only thing that I want to bring up that is a little bit different with this facial paralysis is that if you get to the point of seeing a plastic surgeon for the facial paralysis, they may or may not recommend Botox or Dysport injections. So if you're having a little bit of spasticity or there is some twitching going on in your face, they may do some direct injections to those muscles to kind of help calm them down, okay? And now I'm gonna hand it off to Dana for the second part.
So now we're gonna talk about the rehabilitation treatment. And before we kind of dive right into this, I just wanted to make a little bit of a general statement. The literature actually says that electrical stimulation is not as helpful for facial paralysis as it may be for some other types of disorders. So as we go through this, we're going to talk a little about electrical stimulation, but it may not be exactly appropriate for you because the literature says that even in the acute or the chronic phases, there's low-level evidence to support it. So first we're going to talk about just facial exercises, which we'll talk about in a little bit more detail later. We'll kind of all do them together, which is what we do in therapy. We have facial massage to help kind of keep elasticity of your muscles and the skin around your face. We have biofeedback, which is for someone that doesn't have full paralysis, so they have some movement in their muscles. This has to do a lot with trying to reconnect your brain to your muscles and those signals, and it uses a form of electrical stimulation. And then you have acupuncture and electrical dry needling. And electrical dry needling is kind of like acupuncture, except you're adding e-stim into it, or electrical stimulation or e-stim. One other comment about electrical stimulation, there's different modalities of electrical stimulation. So sometimes people will use electrical stimulation for a sensory approach versus a motor approach. So think about a sensory approach would be like for low back pain. Someone would use e-stim to decrease their low back pain, which may be beneficial for some of you. But the type of electrical stimulation that we're talking about here is really that motor type of electrical stimulation, where we're trying to facilitate an actual muscle contraction of the muscles in your face. So just keep that in mind, that e-stim can kind of be used in different facets. So even if it's not appropriate for you guys in this type, it could be beneficial in other areas of your recovery. And then if someone doesn't have any type of active movement in their facial muscles, they want to use different compensation strategies to help. So some of them could be drinking from a straw, or some of them could be manually closing your mouth so you're able to chew and liquid doesn't come down the side of your face when you're taking a drink of water. Or it could be manually closing your eyes, which is what we'll talk about in a little bit. Another one is kind of pulling your cheek up towards your ears, so when you're chewing, you don't actually chew accidentally on your cheek. And the other one is to change your diet a little bit, which is kind of like what Maria was saying about having food that are a little bit smaller in bite size, softer, and add a little bit more moisture. When you're thinking about the stages of swallowing, what traditionally happens is you put the food in your mouth, right, and we use our teeth to chomp it up into small bits, but it's actually moving around in our mouth to create what's called a bolus, which is using the saliva to create this little like mound of food, this bolus, so we're able to easily swallow it. So if you're not producing enough saliva or you don't have enough muscles in your mouth to kind of create this bolus, it could cause like a choking hazard, or it would actually like fall out of your mouth if you had really severe facial drooping in your mouth region. So how do I do this? This one? Okay. Okay, so now we'll talk about a little bit more about what we do. So in occupational therapy, we really address lagophthalmos, which is a fancy term for saying that your eyes don't close all the way. Traditionally, when you're thinking about blinking, right, you have your upper lid and then your lower lid. And when you blink, your upper lid comes down and then your lower lid comes up. So it creates this like seal, which is really important to protect our eyes from different debris in the air. And this debris we can't always see, right? But an example is like if you're at the beach, because we're in Florida, right? Sand in the air, right? You may not be able to see, but there could be debris getting into your eye, but we blink to kind of counteract that. If someone has facial droop or facial paralysis, you may notice that when they close their eyes, they can't actually make that appropriate seal with their upper and lower eyelid. So you notice the sclera, or the white part of the eye, still showing. And that essentially is really imperative to detect right away, because our vision is our dominant sense. It's super important for everything that we do. And if we're not protecting our eyes, that could kind of cause some challenges down the road. So if you do notice that yourself or somebody else has this lagophthalmos where you see that white part, the sclera, the first thing you want to do, it's usually the OT or the occupational therapist that identifies it first, but our job is to protect the cornea, which is a clear, like a lens that goes over your entire eye to protect your eye. So one of the treatments is to actually have an ointment that's usually prescribed by your physician that you would put directly onto your eye, usually at nighttime, so you would just sleep with it there. Sometimes patients will say that after they use the ointment in the morning, things get a little bit blurry because of the ointment, but as the day goes on, it kind of subsides and it doesn't bother them as much. Other times, sometimes people will say that the ointment irritates them, but usually that blurriness goes away as the morning progresses. The way that I kind of think of it is that if you had glasses on your face and we smeared it with ointment or like a Vaseline or something, and then you wiped it away, there's always going to be that like a little bit of residual on that lens, so it blurs it out. So that's kind of the same thing that's happening with the ointment. So that's one treatment, but let's say that you don't like the ointment or it irritates your eye a little bit. They actually have what's called an eye bubble, which is kind of a funny name, but essentially what it is, it's a clear ball that's kind of like cut in half, so you could have two if you're bilateral impact. And it has adhesive on the end of it, which is meant to go on your skin. So people will put these eye bubbles on, so it kind of just looks like this big, clear, like bulb on their eyes, and they wear that when they sleep, and then they take it off in the morning. You can get those at any like pharmaceutical stores. I'm sure Amazon has it, because Amazon has everything nowadays, but that's another option. And then usually to continue to protect your cornea or your eye, during the day we recommend that you wear glasses, even inside for the debris. If you don't actually wear glasses, you can always purchase non-prescription glasses that you can wear, and definitely wear some type of eye protection when you're outdoors, because again, the debris is going to be a little bit more heightened outside. Occupational therapists also help with neuromuscular re-education of the orbital muscles, so just working the muscles around your eyes, which we'll talk about in a little bit. Physical therapy, again, also helps with the neuromuscular re-education of the facial muscles, along with speech therapy. But what's unique about speech therapy is that they really determine what's appropriate for you related to swallowing strategies or helping you with speech, because if you do have really severe facial paralysis, when you're speaking, we really rely on moving our mouth and our lips in certain ways to get certain sounds out. So that might be impacting like your speech. So the speech therapists really hone in on you being able to manage your food appropriately in your mouth and being able to speak clearly. So now let's get into the fun part. So we can actually all kind of try this together. So if Marie and I will kind of demonstrate, and then hopefully you guys in the audience can try as well. So we kind of divided the facial exercises into different parts of your face. So we have a few for the upper, and then like the middle and then lower parts of your face. These are really just a couple just to kind of get your toes wet in it. There's definitely a lot more, but I think working with an occupational, physical, and speech therapist, they can kind of really hone in on what you're having specific challenges with, and they can add more of a personalized exercise program for you. So the first one we're going to talk about is raising your eyebrows and furrowing them. So if everyone kind of puts their hands like on their forehead and just kind of raise your eyebrows, you can kind of feel like your skin and your muscles actually moving, right? So when you're doing this type of exercise, you want to almost act like you're surprised and your eyebrows go really, really high, and then you want to furrow them back down like you're really mad at somebody.
Think about being mad at Dave last night.
Trivia question.
They were really hard.
I think I got like 2. And a lot of the times when someone has facial paralysis, right, like they might be able to get their eyebrows up a little bit, but not fully all the way. So you can kind of do what we like to call active assist, where you're actually helping your muscles move a little bit. So let's say you lift your eyebrows up, but you can't get them all the way up. You can kind of facilitate some of that motion with your fingers to get the entire motion all the way. And that is essentially kind of trying to retell your muscles, like, hey, you're only getting halfway. This is where I need you to go. So it starts to remember like what it should be doing. So with all of these, you can kind of use a little bit of an active assist technique. So the next one is wrinkling your nose. So to do an active assist of this one, you can kind of put your hands a little bit on your cheeks, and you're kind of bringing like your cheeks and you're furrowing your nose a little bit and bring it back down. And even if you just kind of rest your hands on your nose like how I am, you can, and kind of wriggling your nose, you can actually feel like the facial muscles moving, which is kind of cool. Another one is opening and closing your eyes. So this is one specifically related to the lagophthalmus that we were talking about if you have trouble fully closing your eyes. So you're essentially going to try to close your eyes as tight as you can and then open them really, really wide. For this one, you can assist yourself. You just want to make sure that you're not actually like poking your eye, of course. So you can kind of just gently put your hand or your fingers down a little bit below your eye here, and as you squeeze, you're just gently kind of bringing your skin up and then releasing it when you open them nice and wide. One of the things that I did forget to mention too, that if you aren't able to close your eyes, this is a really good exercise to kind of do throughout the day. So of course, making sure that your hands are clean because you want to avoid infection is really important. But just generally, like always closing your eyes throughout the day is going to be helpful because you're getting the same effect that you would get if you were able to close your eyes or blink naturally. And then we have smiling of the face, so you can kind of like hold your cheeks and feel like your smile, and you can kind of help pull your cheeks up towards your ear to smile and then relax it. And then you can kind of blow air in your cheeks and then make a little like fish face. Let's see everyone's fish face, or like your kissing face, right? Because you're working all these muscles around like your mouth. So those are some examples of some exercises. And again, the physical therapist, speech therapist, or OT that you work with, they can kind of give you more specifically based on where in your face you're having the most challenges. Yeah.
And then for this area of the face too, this is where the massage techniques come into play too. A lot of times people will hold a lot of tension because they'll clench their teeth down. So these muscles in here will get really, really tight. So when having your hands in a similar area, you're just doing little circles along that muscle, like especially if you clench your teeth and you feel that tightness. Kind of hard to do and talk at the same time, but you feel that tightness. Those are the areas that you want to relax your face and do small little circles along that muscle belly to help relax those muscles. Because a lot of times people will get a lot of that tension and they might have some pain behind, like at their jaw, okay?
And then lastly, let's say all of these other types of treatments that we already talked about wasn't successful for you. There is surgical treatment for facial paralysis, but the Facial Paralysis Institute really recommends that this is done in the chronic phases, so either 8 months or even longer out to even be considered. When you're thinking about surgical intervention for facial paralysis, there's a lot of other things that you really want to factor in, right? You have healing time, there could be some contraindications, and there's a chance of infection when this happens. So there's a little bit more of a risk if you are thinking about doing some type of surgical intervention. So it's really imperative to make sure that you're talking to your neurologist if this is even appropriate for you, and making sure that if your neurologist agrees that this is something important that would be beneficial for you, making sure you go to a plastic surgeon that actually specializes in facial reconstruction due to facial paralysis. You don't just want to go to a facial or a plastic surgeon that puts in breast implants or does like a tummy tuck. You want someone that really specializes in this to making sure you're getting the best results, because it is a really complex, challenging surgery for people. So we'll kind of dive into some of the surgical treatments. A lot of times people have heard of Botox injections, and Maria had mentioned a little bit before that sometimes people can have some tightness in their muscles or muscle twitching, and putting Botox in there would essentially help relax the muscle a little bit, which may not be as widely used among the GBS and CIDP population, but it's definitely a treatment option. They also have muscle reanimation surgery, which essentially what they're doing is if your facial muscle isn't working at all, that nerve isn't alive or working, right? So they're essentially trying to take that muscle and reattach it to a nerve that works, which is pretty crazy, right? To try to see if we can get those things firing again so they work. And then they also have nerve grafting and transplant, which essentially is the same thing of trying to give that facial muscle healthy nerves to work, but you're getting that nerve or healthy tissue from a separate part of your body or even from someone else. There's also selective neurolysis, which is sometimes releasing a particular muscle. Like if a muscle's super, super tight, they'll actually release it so you're able to smile. These options that we kind of just talked about really focus on the functionality of moving your face. So being able to smile, being able to manage your food a little bit better, because it's really trying to increase the motor aspect of your face. And then we get into more facial surgeries that just help kind of improve your symmetry of your face, which may not necessarily help with movement, but it's helping with the symmetry. So most of us have heard of brow lifts, eyelid surgery, and facial lifts. They also have facial slings where they can kind of reattach like the muscle in a certain way to kind of hold it up, kind of like a sling. And this essentially just gives your facial expression just better symmetry. As you can see, like in this picture here, this is a woman that actually went through surgical treatment to correct her facial paralysis, and you can see like how amazing she looks, which is really exciting, you know. One of the last things that I just want to mention about the surgical treatment is that, again, this is one of the last resorts if all of these other options didn't necessarily work for you. But if your facial paralysis is really significantly affecting you functionally, being able to talk, communicate with your loved ones, being able to eat and enjoy your food, it may be able to be covered by insurance because it's affecting you functionally and really hindering your quality of life and your ability to participate in daily activities. If it's more for, let's say like your facial paralysis may not be affecting you as much functionally, but emotionally you would feel a little bit more confident in correcting some asymmetry that you have, it may be considered more a cosmetic procedure, which wouldn't be necessarily covered by insurance. And again, these procedures are very expensive. So just keep that in mind if this is something that you in the future want to maybe look into. Then I'll pass it back to Maria just to finish us off.
You would think Dr. Dan Gottlieb would have paid us to put this in here. I promise you, we had no idea what he was going to talk about. We just happened to come up with this picture of smile in the mirror. Do that every morning, and you'll start to see a big difference in your life. And if you heard yesterday, Dan had such a powerful message of look at yourself in the mirror, look at that person in the eyes, right? Well, now we encourage you to not only look in the mirror every day and look at that person in the eyes, but smile. Smiling has such a huge impact on our emotional health that's probably one of the best exercises you can do every day.